Okay. Hello, Janey.
Hi, David.
So Janey is a research nurse with a background in sexual health and HIV nursing. She has been involved in some of the landmark studies that helped progress global understanding of HIV. That's the AURAH study and the AURAH2 studies, and the partner study, which really helped U equals U, or HIV uninfectiousness, become a science fact. And she did her thesis on chemsex, chemsex and the city. We've been friends for ages, and Janey helps me to understand the academic literature that I really struggle to. My brain does not work that way, and Janey's always at my rescue trying to help me understand it, which is what you're going to do today. Thank you, Janey, for joining me.
Oh, thanks, David, but don't sell yourself short, because I know that you understand a lot more than you are letting on. And actually, it's usually me coming to you saying, what do you think of this? Or what's going on here? So
that's true. Well, I have to say, I really don't pretend to understand some of the stuff a lot of the time, but I really don't. But our conversations, yeah, I help you with, I think, some cultural background to the research questions that you're planning to do.
exactly.
And I don't even remember how we met. It was a long time ago, right?
We met because I was working as a sexual health nurse, and you came into the clinic that I was working in. Yes, about 10 years ago, probably. And then after that, my interest kind of peaked in chemsex, and I had a great opportunity through the PhD to really explore chemsex within the UK. And you were really a large part of like helping me look at my research questions and what it was that I wanted to kind of to answer in terms of trends, and yeah, so yeah, it's a symbiotic relationship, I think.
A lot of the quite famous studies you've worked on have been very much around behaviour and behaviour of gay, bi and other men who have sex with men, which is really what chemsex is all about. You know, it has HIV consequences and associations, but it's not all about that. But it is certainly about behaviour, and so you've had a really good window onto some of Game's behaviour because you've been asking them very personal questions, and they've been brilliant and coming forward and answering those questions and talking to you about those things.
Yeah, this is true.
Can you tell us about what a research nurse's job is? Let's start there.
So my research nurse job has involved, well, in the last 10 years, my background is sexual health and HIV specialist nursing. And then in the last 10 years, I've been responsible for setting up studies and coordinating studies across clinics in the UK that are collecting data on, gay men's sexual health and behaviour and mental health and all the other kind of things that come with that. So recreational drug use, chemsex, and then looking at that data and trying to look at sort of trends and associations with outcomes, so with HIV or STI acquisition. And so the two studies that I've been really a large part of have been the AURAH study, which was just a snap point in time in 2013-14, looking at a large group of HIV negative men who were attending sexual health clinics all across the UK, and asking them just one set of questions on a questionnaire, and that involved questions around their mental health and well-being, their physical health, their sex lives, their drug use, and how they felt in terms of their friendships and whether or not they were comfortable being out. And then following on from that, we did a study called the AURAH2 study, which was the attitudes to and understanding risk of acquisition of HIV over time, again in gay men, which used that baseline data and then asked more people to take part in an internet-based study where they were sent questionnaires every 4 months, similarly asking about HIV risk, HIV testing, sexual health, what they've been up to in their sex lives, chemsex, recreational drug use, and then physical and mental health. And then in the last 2020, was it? Yeah, just at the start of 2020, before COVID, I wrote that up into my thesis, and then promptly went on maternity leave.
And I miss you.
Oh, well, I very much miss being, well, I don't know, I suppose in a way I've missed kind of the COVID year. So it's actually nice to be back. I did a little stint with COVID and ITU at the start of this year, but it's very nice to be back in a kind of research capacity, and looking on to the next thing, which is going to be looking at a new model of care for people living with HIV and people who are struggling with mental health and anxiety issues, and how we can kind of tap into a more sort of holistic model of care for those people to improve their outcomes.
Well, post-COVID, that's a really important study, I think. I'm looking forward to that.
I hope so, yeah.
One of the things you were doing very early on was there was a time 15 years ago when people thought that only HIV positive men were doing chems, because they were so easy to research. A lot of people also thought that they were studying chems use, but in very broader context, not just sex. And that was confusing some of the data too. And separating chemsex from regular recreational drug use. And very early on, you've been sort of identifying chemsex as an actual thing. And that's been really, really helpful to not just to me, but a lot of the research you've done has helped a lot of the people I work with around the world, because here in London, and you can talk to me about this, we've got really, really good chemsex support going on. But before we get there, sorry, I'm sort of distracting myself. Medicines are an important tool in HIV prevention. In fact, if every HIV positive person in the world was on HIV medicines and undetectable, the HIV epidemic would end. Or if everyone who's sexually active in the world was on PrEP, then no one could catch HIV. So again, the epidemic would end. But human behavior is complicated, and there are lots of reasons why this perfect medicine doesn't fix everything. And your research is always focused on behavior.
Yeah.
Which is so hard for, especially, I think doctors and nurses struggle to understand behavior, because I think a lot of the training is very science focused, and there's a solution to that and a problem for that and a fix to that. And I work in many medical settings where my job is behavior, but it's in a very sciencey area, and I do feel a gap. Your research is all about behavior, and most often the behavior of gay men or men who have sex with men. So can you tell us where human behavior becomes challenging for HIV epidemic management?
Yeah, so I think you've really touched on it. There is definitely a disparity or a disconnect between sort of how we medicalize something and have treatments for it, and then how that gets translated into actual practice. And I think really in terms of human behavior, from our studies, what we've seen is that there just isn't one solution to fit everybody. And that completely stands to reason, because not everybody's the same. People have different ways of going about forming relationships, maintaining their sex lives. And for some people, that is a very kind of traditional relationship. And for others, that is a very different relationship. And you've got a huge spectrum of how people manage their relationships, manage their sex lives. And then there's so much that bleeds into that, from kind of, you know, past history of experiences of coming out and of experiences of being out, and how that is connected to how you feel about yourself and self-esteem. And so I think really, like, in terms of human behavior, you know, we, like you said, we've got all these amazing things that have happened, particularly within the last 10 years around HIV prevention. So if everybody who had HIV was diagnosed with it and started on treatment, then they would all be undetectable and all unable to transmit the virus. Thank you very much, Partner Study 2, which I was very happy to be a huge part of, and was just the most incredible study. And I think that PrEP, again, has kind of completely changed that biomedical perspective from the negative perspective. So people who are negative could then take this medication either on demand, as and when they thought they were going to have some action, or on a daily basis if they were going to want to do it on a more, like, just have a sort of structured approach to it. But, you know, that isn't going to fit everybody. We can't diagnose everybody at the point of infection. And there are people who are either unaware of PrEP, unable to get hold of PrEP. There's still huge issues around accessibility. You know, and the thing that we hark back to or have relied upon sort of traditionally is condom use, which, you know, from the very beginning, we knew that that isn't just going to be like, they don't fit, they don't work, they're not comfortable, whatever. You know, there's lots of different reasons that people don't use condoms. There's lots of different reasons that people don't use PrEP or can't get PrEP. And there's lots of reasons for people not being diagnosed or not being engaged with clinics. And so I think the most important thing, really from my perspective, is that men who are sexually active should be able to access some kind of service that is open dialogue, non-judgmental, non-discriminatory, and able to have that conversation with somebody. Or it doesn't necessarily have to be in person. You know, we're seeing, like, post-COVID, a huge shift away from having to be face-to-face with people, but being able to access a service that can then have a really clear dialogue with somebody that makes them feel comfortable and safe and secure and, you know, important and open to talk about what it is that, you know, whatever, however their sex life is playing out, and that they're not judged by it. And then that allows people to then make and take those decisions about what is the best and safest way to ensure they have a safe sex life. And so really, you know, with all of these kind of biomedical interventions that we've got going, like, what it actually boils down to is how that individual person accesses those, and how do we as healthcare professionals or activists or grassroots organizations that are working within the sector, how do we make those open and accessible to people?
It is really important. I'm thinking of colleagues I have in, say, Slovenia or Mexico, where a clinician, someone who can prescribe PrEP, or at least talk to someone about PrEP and how it can protect them from catching HIV, really wants to know if this person is, say, engaging in chemsex, because that puts them at higher risk, and that clinician would really like to talk to that person about PrEP. But if that person is too frightened to talk about his drug use because he's living in a city where it's stigmatized or shamed, or because services are not talking about it as a thing, you know, they're just labeling it as drug use, send them to a heroin clinic. But if our services were places where you could destigmatize, talk about these things, then better care and HIV prevention happens more organically.
Yeah, and we've had this conversation before, David, because I remember when I was first sort of designing the questionnaires for the AURAH study, and we were looking at, you know, not just sort of how or what the clinicians need to talk about, but also how people, like, what traditionally they feel like where their needs lie, and like recognizing that actually chemsex specifically, or drug use that leads to sexual activity, then is part of a sexual health service, or is part of a service that is incorporating sexual health as well as drug use. Because, yeah, you know, like you've said 100 times, a gay man who is using drugs for chemsex isn't going to go to a clinic that is dishing out methadone for heroin users, and there's that sort of, you know, where does the service fit for those people? And, you know, like you're saying, Mexico, I don't know a huge amount about Mexico, but, you know, a lot of that does actually boil down to kind of human rights, and how people, you know, like, in terms of like whether or not people are able to be open and comfortable with their sexuality to people in positions of healthcare or sort of more or authority, whatever authority means. But and, you know, and the stigma around sexuality, and the stigma around then chemsex, and, you know, it's such a kind of complicated process that actually, I think, you know, we are incredibly lucky in the UK mostly to have a very open, equal, mostly community and services that are actively engaged in addressing these issues, so that we have places, not equally across the UK, I'd hasten to add. Like, there are lots of places where I think there is a lot of need for chemsex support that just doesn't have it, because it's not necessarily recognised as an issue there. And that's why I think, you know, as we go forward, particularly kind of post-COVID, how we move services into a far more accessible. I know you do a lot of stuff online and a lot of like chemsex support on your webpage and things like that, but, you know, finding things that are accessible to people but you know, what about people who can't get online? What about people who, so there's so much that you know, even as a sort of a country that does recognize chemsex as an issue, like we still have inroads to make.
It's true, it's true. I know that a lot of the traditional drug services in the last 3 or 4 years especially have been working really hard, partly because it's now written into UK drug policy and things like that. But it still is, you need to be able to talk about gay sex and everything that goes with it. Fucking, dildos, bums, all the other things that go with it, and the drugs and the chemsex and the grinder and the rejections on grinder and how you write your profile. These are a much a part of the drug use issue, and the service trying to provide support needs to understand that context and culture.
Yeah. And I think that's why, you know, we have found that sexual health services have been a place that have been a kind of logical landing spot for that need, because, you know, as sexual health nurses, traditionally, hopefully, we're very used to talking about bums, dildos, fucking, that kind of, you know, everything. And then what initially happened was we were beginning to be like, oh, but we don't really know about like what these drugs are and what they mean, you know, and so actually we had to catch up with what was happening within the real time, to kind of improve and move our services on to be able to kind of handle that, because we're very used to talking about the sexual health side of stuff. But then when we were seeing people coming for PrEP, because this was before, you know, before PrEP was really an intervention tool, you know, we were just seeing a lot of people turning up for PrEP, recognizing that they had a risk, and then, you know, us sort of being like, oh, and what's this drug or what's that drug and how does that make you feel? And actually, you know, there is so much to be said about just, sometimes I'm like very open to saying, oh, and what is that? And how has that made you feel? Or is that okay? Or did you feel okay with that? Or is that what you wanted? You know, like just being completely open with somebody. And then obviously, you know, we've had a lot of like great catch up in terms of like an over, like an over link between drugs and sexual health, particularly through you and your work. So that more and more, instead of playing catch up and being like, oh, right, what was that? How did that make you feel? I'm like, okay, I understand that. I get it. Yeah.
If there's one thing that, I mean, there are people who've tried to do chemsex research through online surveys where it seems like a good idea, but at the same time, there are people who might be engaged in problematic drug use, and I tell you, when they see a questionnaire about their own drug use, the first thing they do is denial and turn away from it. So it only captures a certain kind of person. But one thing you do know about chemsex is anyone who engages in chemsex is going to be needing to go to a sexual health clinic. It's just, it goes with the package, you know, and so that's the place where we start the research. It's a place where we start the care. It's a place full of people who talk about sex, and often gay sex, really easily. So it is the starting point. I agree with you. And for everyone listening around the world, and all of my friend activists around the world who are trying to make this happen, they are trying to do just that, trying to make it happen in place. The starting point is chemsex support should happen in a place where gay sex is discussed easily, more so than drug use. It's the gay sex component. And you've got a new piece of research that kind of makes that point. So I came across it via an article online, but can you tell me firstly about this new piece of research that got me all excited?
Okay, so yeah, sure. So this is a piece of research that has come out of the AURAH2 study. So this study that was following this group of gay men who were initially HIV negative. We had over 1,000 men who enrolled, and they kindly gave us 4 monthly questionnaires, online 4 monthly questionnaires over a 3-year period. So this credit has to go to Nadia Hanum, who wrote up this analysis and wrote up this paper really beautifully. But what this analysis has looked at is overall, from the time that we recruited people, which was 2013-14, through to the time that all of those people had kind of finished their final online questionnaire, which for some was up as far as 2018-19. So we looked at this period of time, 2013 to 19, and we showed, or the paper showed, that there'd been a really substantial decline in HIV infection in gay men over that period of time. And that was reflected in the national data. I think it was 2015, 16 that we first started seeing these declines in HIV incidence among gay men at a national level. And there were a number of reasons that were ascribed to that. And one of them was starting treatment as soon as, or as early as possible after somebody had been diagnosed, because we knew overwhelmingly that it was better for somebody to start treatment sooner if they were diagnosed with HIV for their own health outcomes in terms of their mortality, but then also in terms of like other comorbidities or other illnesses that they might get if you wait until a certain CD4 count threshold. And then treatment as prevention, which again, credit to the Partner 2 study, really demonstrated that if somebody was diagnosed with HIV and then started taking effective antiretroviral treatment and became undetectable, that they could no longer transmit the virus. And then really, again, in 2016 was the PrEP study, which demonstrated that if HIV negative men were taking one tablet of antiretroviral treatment called Truvada, they could then stop themselves from becoming HIV positive or stop themselves from catching HIV. And so there were all these things that happened over the course of this study period that really were fantastic in terms of HIV decline, but also for the study meant that we were predicting, if trends had carried on the way they were when we set up the study, that we would be catching a lot of people with new HIV diagnoses. But actually what we saw was a very small number of people getting HIV whilst they were part of the study, and which was fantastic. So what we did was link the people with their consent. Everybody who took part in the study agreed to have their data linked to our national HIV surveillance database, so that we could make sure that we were capturing even those who had dropped out of the study. You know, some people might have just dropped out for no reason at all. They'd had enough of answering questionnaires. Some people might have been diagnosed with HIV and thought, this is the last thing I want to do, like complete another questionnaire about this right now. And so one of the strengths of this study was that it could capture that if that had happened to those people, and we could see that they had been diagnosed with HIV through this linkage of data, and then we still had all of their questionnaires that they had previously answered before that diagnosis. And so firstly, the study showed this really fantastic decline in HIV incidence over that period of time in the UK and England. But then what we were able to do was really look at the factors that were associated with acquiring HIV during that period of time. And so really, the factors that came out as being the most strongly linked to HIV acquisition were injecting drug use, including chemsex injecting drug use. So that's kind of the most, I mean, in terms of like your work and probably the majority of people who are maybe watching this or listening to this, you know, we know that injecting drug use is a big factor for potentially for HIV acquisition. But in this case, it was chemsex related injecting drug use as well as other injecting drug use. And then the next factor that was associated most highly with HIV acquisition risk was chemsex use, non-injecting use. But there was a big difference, again, between the injecting drug use and the chemsex drug use. And then there were all these behavioural factors as well. So like a larger number of condomless sex partners, with HIV positive partners, group sex, and then people having sex for drugs or money. And so there was a whole lot of behavioural factors that were then also associated with that increase in risk of acquisition. But I think the one that has stood out in terms of this article that you read was the chemsex one. I think it is just important to say that it wasn't a large number of people who were injecting drug who were reporting injecting drug use within the AURAH2 study. It was actually around 3%. And of those, all of those also reported chemsex drug use within the last 3 months that was collected at the same time as they reported this injecting drug use. So we feel quite sure that we can say that some of that was certainly attributed to injecting drug use through chemsex. And that as a factor increased the risk of later testing positive for HIV by about 28-fold compared to those that reported no recreational drug use at all. And then chemsex and non-injecting chemsex, that increased the risk of acquiring HIV at a later, being diagnosed at a later date by about 6-fold compared to no recreational drug use at all.
Janey, if a person who's injecting chems becomes HIV positive, do you know if they became infected through the needle or through anal sex?
So our data definitely didn't capture that. And I think it would actually be very difficult to, you'd have to do very, very in-depth event.
Yeah, I can't imagine how it would be done, really.
I'm not sure how you would capture that. I mean, we do know that the risk of acquiring HIV through like unclean and through unsafe injecting equipment is really high. And I don't know what the actual kind of, I don't know, because there's so many nuances, aren't there, then when you kind of drilling down into chemsex, like whether or how long the chemsex of that particular point of infection goes on for, how many partners, how many people were taking, it's so difficult to then start trying to work out like where that actual infection came from. But I think in a way it doesn't matter. Like in a way, like what does it matter? What matters is that actually we know that as a practice is something that could be prevented by either that person having access to clean and open clean needles, or clean and good injecting equipment, or being comfortable with the people, or being able to talk and be comfortable with the people that they're partying with, or also being on PrEP. And there is what struck me about this analysis was that actually there was one of the other it's not necessarily behavioral, but what was really also associated with HIV acquisition was the fact that people had presented for PEP. So they had recognized that they'd had a risk. They came for PEP. PEP use was highly associated with HIV acquisition. And that to me was quite sad, because it kind of shows, well, that is a missed opportunity, because if that person presented for PEP, perhaps they were engaged with services beforehand. They certainly knew about PEP to come and access it. And yet they became HIV, they acquired HIV. And so I think that is something that kind of stood out to me about this, about the analysis, was that we've missed the opportunity for some people to prevent that from happening.
Yes. I don't know if you know the answer to this, but is a person taking PrEP protected from catching HIV through injecting drug use?
I don't, in honesty, I don't know. I have to say that injecting drug use and PrEP are not are not my areas of.
I think it hasn't been studied yet. I'd just like to assume that it would, but I can't make that assumption. You can't make any guess either.
Yeah, I mean, I think in terms of mechanism, like PrEP as the mechanism of prevention, yes, has the potential to stop that from happening. But I think, there is never you can never say that something is 100% effective. You can never say that something is 100% going to work. And I think all of that then does boil down to that individual incident, in terms of like the person's immunity, the amount of viremia that is potentially, and we know that if you're injecting if you're sharing needles with somebody who's positive, whether or not that person was on treatment, there's such a huge range of things that could impact upon whether that, as an actual one person case study in front of you, could then whether PrEP could work for that person. I think what's kind of like I said, one of the things to focus on is the fact that, if somebody was on PEP, the chances are that it would be more likely that they wouldn't get HIV, rather than saying, can PrEP prevent HIV from needle sharing? I mean, yeah, it's a tricky one, because like I said, you can never say 100%, but we do know that PrEP is incredibly effective in nearly all in all scenarios.
I think there was a Bangkok study about injecting drug use and PrEP, but I believe it was...
Oh, interesting. I'm gonna put that down to when I was on maternity leave, and I need to catch up on it.
I'll send you a link, but I do think,
Yeah,
I actually wrote a little article about it once, about 10 years ago, but it was, I believe that the research wasn't ethical, or it had some problems about it, which is why I think it was Sheena McCormick told me to look at it carefully, or not rely on it too heavily. I'll send it to you anyway.
Well, Sheena is the lady to know all about PrEP, so I guess if she's saying look at it carefully, then that's probably quite good advice.
It's just me looking at academia carefully doesn't make any sense at all, because I can't make head nor tail of it. We'll do another Zoom topic about that another day, I guess. Okay, so yeah, so it was a small number of people, but it was an identifiable association. Yeah.
Yes, exactly.
If you had done this research in another city, which has less chemsex support available, do you think the findings might have been different?
If we'd done this study in so I think there's always going to be sort of the other conditions that kind of have meant, we've seen we've seen a smaller number of people are diagnosed in this study than we anticipated. And like how that plays out in terms of chemsex support, from in this study, the clinics that we recruited the gay men from have incredible chemsex support services. So, outside of that, like that in itself is a limitation of the study. We knew that we were recruiting from large sexual health clinics in large cosmopolitan cities with a large number of gay men, where we knew that that the cities had been shown to, in other studies, like in the European Men's Internet Survey, had shown that there were high rates of chemsex reported in those cities. And so, so we were recruiting from a sort of high chemsex area, but we were recruiting from services within that area that were actually, kind of sort of addressing the balance a bit by providing great services. So I think potentially if we were recruited from another city that didn't have chemsex support services, maybe didn't have access to PrEP, didn't have necessarily access to sexual health services for other kind of STI treatments and dialogue, then yeah, sure, we would. I think it's likely we would have seen a much stronger association.
One thing I do know for sure is that the clinics that your research studied, and many of them in London, chemsex patients were identified as there were posters on walls very early on, more than a decade ago, and clinicians in those settings were identifying them and saying, I would like to talk to you about PrEP, as soon as PrEP was on their radar. So they were introduced to HIV prevention technologies early on, immediately, because they were identified and because the city was on it. And I know I asked you the question, but the answer is that isn't happening in most cities around the world. There are people who walk into a sexual health clinic and they can't say they did chemsex. There are people who can't walk into a chemsex clinic and they say they had group sex or gay sex. So I mean, I think the HIV incidents that would have happened in your study in other clinics in other cities around the world,
without access to PrEP, I completely agree. And
so, because London is unique in that chemsex support is recognised as an integral ingredient of an HIV prevention package for the city. Chemsex support is available in most sexual health clinics and LGBT charities in London. It's written into the public health guidance. It's recognised as an issue by the UK Drug Policy Commission. But there are many cities in the world and colleagues of mine work in these cities, and I talk to them on a weekly basis, and they're listening into this, and they're very aware of the privilege we have in London and of these services, and they're still fighting for chemsex to be recognised as a health issue that needs some recognition and investment from senior public health. So it's possible that there are senior public health people listening to this too, or that my activist friends are sending this video to them. So, Janey, do you think chemsex support should be recognised as an important issue in regard to HIV prevention in other Western countries and cities? And do you have a message for any public health officials that might be listening to this?
Well, thanks, David. So, I mean, we know the data is clear. And like I said earlier about our, some incredible forums that are bringing together people from all over Europe and a bit further afield and from your international work. But, there is data to show that chemsex is happening everywhere. And we know that chemsex puts you at much higher risk of HIV acquisition. We know that there are lots of people that can manage their chems safely and can enjoy chems and may go on, and that there are periods of risk within people's lives where they may be doing more chems than not, they may be moving out of chems and then coming back into it. But we do know that we have a very cost-effective preventative tool to stop them from getting HIV when they are in that higher risk period of time in their lives. And I cannot see how it wouldn't be a cost-effective measure, because unfortunately, I mean, it is what healthcare systems need to live up to produce a cost-effective measure that will then benefit people. And actually, we know that preventing HIV infection is far more cost effective than treating HIV infection for the rest of somebody's life. So to me, and I think hopefully to you and to any public health official listening to this or watching this, I mean, it is a no-brainer, because actually the intervention can be very cheap. It's talking, having an open dialogue. If there are services in place that are offering sexual health to gay men, then training those services or training those people or offering people the opportunity to learn more about chemsex or how to talk about chemsex. And then, I mean, there is another key ingredient to that is having access to treatment as prevention, or having access to PrEP as prevention. Or if you don't have access to either of those, talking to somebody openly about how they can minimize that risk in terms of whether or not it's regular testing, condom use, open dialogues with people, feeling safe with the people that you're playing with, making sure that you can have those open conversations with people. But I mean, so it does seem to me that, we are increasingly at an international level seeing that there is a reason why we can really focus our intervention efforts on a much smaller group of people. And whether or not that is in different countries, there's going to be different risk factors for that. But in countries where the sort of higher prevalence of HIV is within gay men, then really kind of looking and understanding how much of that is due to chemsex or how much of that can be related to chemsex, then it is of course it's got to be on the public health agenda, and of course it's got to be something that's invested in, because it is cost effective to prevent HIV infection. It's cost effective at a national service level, and it's better for the individual at the point of care, of caring for somebody and looking after somebody and supporting somebody through these different points of time in their life.
And the cities that are winning the HIV battle and sort of ahead of the game in regard to their targets are the ones that have great chemsex support. And
yeah,
you and I are working at HIV and sexual health sector, but there's another group of people watching this who just work in harm reduction in drug use, who might not be so aware, other kinds of drug use might not be so at risk of HIV as chemsex patients might. So it's not just, so in regard to harm reduction, PrEP and keeping people adherent to the HIV medicines is one of the greatest harm reduction tools there absolutely is in regard to HIV epidemics for chemsex people. I wanted to add that to what you said too. And it's not just a matter of providing medicines to people, it's providing these medicines to the right people. So if you are, wherever you are, if you're a clinician working anywhere in the world, and that you handle out, you're really good at PEP and PrEP and adherence to medicine, things like that, but you're reluctant to talk to people about whether they do drugs or not, you're not targeting the right people with the right kinds of interventions. So find a way, reach out to a community organization, reach out to a gay charity, or reach out to somebody where you can skill up on how to have those conversations about inviting people to talk to you about their drug use and their chemsex. Put it on your websites, put it on your Facebook pages, destigmatize it. It's a real issue that people really, really do, and just having conversations about it improves their outcomes. Oh, that reminds me of another thing, Janey. Another piece of research you did longer ago showed that just the fact of a person talking to someone like you, a researcher, with questions about their life and well-being led to better health outcomes in regards to drug use?
So we think that through the AURAH2 study and through the repetitive nature of the online questionnaires, we realized, or had to kind of consider, that potentially having this ongoing 4-monthly reminder about sexual health and well-being and physical health and HIV could have led to this reduction in, we saw over the period of time that we followed people up in AURAH2 in the UK, a substantial decline in chemsex and all the drugs associated, or the drugs used for chemsex. And we couldn't sort of unpick the reasons for that, but one of them could be that it was because they were having these ongoing questionnaires on a regular basis that caused people to reflect on, oh, am I actually, is that what I want to do, or am I happy with that, or should I go and get a sexual health check? And so, you know, just by nature of the fact that people are kind of talking about something, or having, you know, not even in our case talking about it, having a questionnaire in their inbox, asking them, you know, and we tried very carefully to make sure that the questionnaire said, hi, how are you doing, before we start asking about how's your sex life, what are you doing, what drugs are you taking, da 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 da. It was, hi, how are you, thank you so much for your time, and you know, this is hopefully going to be a, you know, a brief questionnaire just to ask you about how you've been over the last 3 months and that kind of thing. And yeah, potentially that could have had a positive outcome in terms of how people manage or reflect on their sexual health and their relationships and drug use.
The reason I liked it so much is because there's a difference between hardcore extreme addiction and people just recreationally engaging in chemsex. There are a lot of people who sort of are struggling with chemsex, or it's become a habit, have just never thought, maybe I should try a weekend off. It's just never occurred to them, because it's what you do. Same way that, you know, you might find yourself going to a bar every week after work and you have a drink every time. And once somebody says to you, you know, just because you're coming to a bar, you don't have to drink alcohol. And you thought, oh, I never occurred to that. That's right, I don't. I was just drinking it autopilot. So there's a lot of people engaging in chemsex that just do drugs autopilot, because that's what everybody else does, because that's how Grindr works, because that's what I've always done. And it's never occurred to them to think about, what do I like about sex? What do I want my sex life to be like? Do I want to have a drink in this bar, or do I want to have Coca-Cola? Just these thoughts that may help people reflect on what they want from their lives are really powerful tools that any human friend, mum, dad, clinician, HIV nurse, a doctor can do. And it's really effective. I know from experience.
Yeah, no, I completely agree.
Okay, so Janey, as a kind of final question then, you've had so much experience. I mean, you're my favorite chemsex researcher, and you've done so much of it. And you've even done research that had nothing to do with chemsex, but you've delved in and tried to find associations anyway. You've just had so many conversations with gay men about their sex lives and the things they're struggling with and the challenges because navigating gay love and gay sex and gay life and hooking up is complicated in a city where HIV has a strong hold. You've had a unique window into that experience. Have you gleaned anything from those conversations, from your research? Do you have any musings about this community?
I think so. My overriding impression of everybody who I've come into contact, either through sexual health nursing or HIV specialist nursing or research, is that, you know, the HIV epidemic was a huge, has been, but historically the 80s, 90s, led to a huge coming together of people to fight for an outcome that was better for individuals at the time. And that, like, I'm always completely in awe of how much was done by the community to progress research around HIV care, medication. You know, it has absolutely driven antiretroviral therapy to being what it is today. And then more recently, it has completely driven PrEP to being more accessible. And, you know, when it wasn't sort of available on NHS England, Prepster, and I Want PrEP Now, like I think time and again, I've been completely amazed at how people have come together as a group to get what is needed for their community. And I think that is a huge, you know, that to me comes out of caring, like caring for one another, wanting what's best for each other, and trying to kind of get equitable, fair access to drugs or medication or evidence that is going to improve people's lives. And I'm constantly in awe of how that has happened. And I think in terms of sort of a community, like what how I see that is one of togetherness and kind of operating out of a sense of kindness and compassion for one another, which sort of drives the impetus to make things better for each other. And I think with chemsex, it's still really important to remember that you know, everybody has different reasons for doing things and has different reasons, like the question you asked me first about behavior. Everybody has different reasons for choosing to do things their way or a different way. And I think actually kind of coming together in a understanding, compassionate way to help that individual, but as a collective group, to kind of move forward and, you know, potentially support each other. That, like, you know, that there's no kind of, to me, I can't think of a better example of how a community can work together to do that. And I think that is really, really important in how chemsex is, or people, how chemsex is sort of, I don't want to say dealt with, but how chemsex is kind of supported, looked after, cared for, you know, because it's by peer-to-peer dialogue that you then kind of can understand or move forward with, like, actually accessing a service, or kind of understanding or knowing, you know, oh, well, you could do this, or so it, like, you know, and then the service itself has to be non-judgmental, non-discriminatory, open, caring, kind. It just kind of, yeah, I mean, it just boils down to just looking after each other, being kind. And I think, like, you know, we know, like I said, that's what the gay community, to me, kind of embodies that, seemingly. From my experience.
Well, mine too. While a lot of my peers were being activists in regard to HIV decades ago, I was just getting high, and I'm very grateful that even though I wasn't capable of doing it at the time, my community were fighting for me. From what you just said, you clearly have a lot of compassion for humans and for behavior. And that is what makes your research so brilliant, and you so brilliant. And that's why I value you as a friend and colleague. Thank you for today, Janey.
Thank you, David. It is always lovely to chat to you. And I very much appreciate everything that our work has together led us to do, and really recognizing actually all the people who have taken part in that and given time to us. And you know, that's just like another example of an amazing community. So I'm very grateful to all of you.
Lovely. Bye-bye then, Janey.